Hello friends, today we will discuss about the femur bone. As you can see here, femur is the strongest, longest and the heaviest bone of the body, and it is the bone of the thigh. The literal meaning of femur is thigh itself. So being long bone, it has an upper end, lower end and an intervening shaft. Coming to the side determination, the upper end presents a rounded head which is directed upwards, medial and forwards, whereas the cylindrical shaft is convex forwards. You can see here, shaft is cylindrical and convex forwards. Lower end is enlarged into two condyles. In anatomical position, the head is directed upwards and medially, whereas the shaft is directed obliquely downwards and medially, and both the condyles lie on same line. So these 3 points are important to hold femur in anatomical position. It is easy to hold femur in anatomical position. Just keep both the condyles on the table. So you can see the upper end of femur is directed a bit posteriorly and laterally, whereas lower end is directed downwards, forwards and medially. Coming to the features of the femur, the upper end presents, as I already told you, head, neck, a lesser trochanter and a greater trochanter. Between the lesser and greater trochanter, you can see a intertrochanteric line anteriorly, whereas intertrochanteric crest posteriorly. This is the head, this is the neck, this is greater trochanter, what you can see here, and you can see here postero inferior to the neck, you can see this is lesser trochanter. So the upper end meets the shaft anteriorly between the two trochanters. This is the intertrochanteric line, whereas posteriorly this is intertrochanteric crest. Coming to the head, head forms more than half of a sphere and it is directed medially upwards and forwards, whereas the head of the humerus is directed medially upwards and backwards, whereas the head of the femur is directed medially upwards and forwards, and below and behind the midpoint of the head or center of the head, it presents a depression here. This is called as Fovea Capitis. Fovea means depression, Capitis means head, and this Fovea Capitis gives attachment to Ligamentum teres of the femur, and its head will articulate with the acetabulum of the hip bone. You can see here the head is articulated with the acetabulum of the hip bone to form the hip joint. Here you can see the direction medially upwards and forwards, and if you see here, this is Fovea Capitis. The entire head is covered by the articular cartilage, which is thick in the center, thin at the periphery. Next, coming to the neck of the femur, it connects the head with the shaft and is about 3.7 centimeter long. It presents an upper border here, upper border, and lower border. Upper border is concave and horizontal, whereas the lower border is straight and oblique. It is straight and oblique, and the anterior surface is flat. This is the anterior surface of the neck. You can see it is flat and meets the shaft at the intertrochanteric line, as we already discussed. This is intertrochanteric line anteriorly and is entirely intracapsular. The articular cartilage of the head may extend to this surface, whereas the posterior surface is convex above downwards. You can see this is the entire posterior surface, which is convex above downwards, whereas concave from medial to lateral, and it meets the shaft at intertrochanteric crest. This is the intertrochanteric crest of the femur, and posterior surface is not completely intercapsular, only more than half of it is intercapsular. So this much is in the, it is 1 centimeter medial to this intertrochanteric crest. It is covered by capsule, and posterior surface is crossed by, this surface is crossed by the tendon of obturator externus, which goes and inserts into this trochanteric fossa. So this is the obturator externus will come here, and neck make an angle with the shaft, which is around 125 degree in the adults and around 160 degree in children's. The angle facilitates the movements of the hip joint and is strengthened by the thickening of the bone on the medial side along its concavity. Sometimes it is called as calcaire femoral. You can see calcaire femoral here. The bony thickening that you see sometimes, that is calcaire femoral. And there is also an angle of antiversion, which is the angle of antiversion formed between the transverse axis of upper end and lower end. When you see here, when you see that this femur in this transverse plane, it is the angle formed between the transverse axis passing through the lower end and here upper end. This angle is around 15 degrees. It's angle of femoral torsion, and you also see the trochanter, the shaft angle, that you can see if you draw a central line passing through the middle of the shaft, then one more line passing through the tip of the greater trochanter here, and one more angle is there, that is the trochanter shaft angle. You should draw a horizontal line at the base of the lesser trochanter, then a midline passing through the middle of the shaft of the femur, then a line joining the highest point of greater trochanter to this line. So this angle is called as trochanter shaft angle, and it is around, it extends from 5 degrees to 15 degree. On average it is around 8 degrees in line, and it is very important in assessing or putting the antegrade intramedullary nail into the shaft of the femur, and this forms a junction between the cancellous bone and what you can say compact bone. So this angle is very helpful in putting the intramedullary internailing of femur. And now coming to greater trochanter, it is roughly quadrilateral at the junction with both neck and the shaft. You can see there, and it presents the upper part of the greater trochanter passes to the center of the head of the femur. Greater trochanter has an apex. It has an upper border here. It has an apex, upper border, and a lateral border, and presents three surfaces here. This is the anterior surface, here is the medial surface, and here is the lateral surface. So anterior surface is rough. Medial surface presents a rough impression above, and it presents a trochanteric fossa below. Here you can see the trochanteric fossa of the trochanter. You can see here is the upper border, and here is the trochanteric fossa, and it presents a lateral border, lateral surface. Here is the lateral surface. It is divided by a groove and by oblique ridge, which is directed downwards. Lesser trochanter is a conical prominence directed medially and backwards from the junction of the posterior inferior part of neck with the shaft. This is the lesser trochanter, what you can see here, and you can see intertrochanteric line here. Intertrochanteric line marks the junction of anterior surface of neck with the shaft of femur. There is a prominent roughened ridge which begins above at the anterior superior angle of the trochanter as a tubercle and is continuous below. This is the upper part, and continuous below with this spiral line that you can see here. Spiral line is here. Spiral line in front of lesser trochanter. Spiral line winds around the shaft below the lesser trochanter to reach the posterior surface of the shaft. That you can see here is a spiral line, that is spiral line part, continued part of intertrochanteric line, whereas posteriorly intertrochanteric crest marks the junction between the posterior surface of neck with the shaft of femur. It is a smooth rounded ridge which begins above at the posterior superior angle of the greater trochanter and ends at the lesser trochanter, and it presents a rounded elevation little above the midpoint of it, that is called as quadrate tubercle, to which quadrate femoris muscle is attached. You can see here the Fovea Capitis gives attachment to ligament of head of femur, or also called as ligamentum teres capitis femoris, which will be attached to the acetabulum. And during the earlier days of childhood, the branches of acetabular or obturator arteries pass through this ligamentum teres to supply the part of head, as the head is not completely fused with the neck. And in the adult, when the head completely fuses with the neck, the retinacular arteries coming from medial and lateral circumflex femoral arteries supply the head. So during the earlier days of childhood, the ligamentum teres transmit the branches of obturator artery to the head. And now you can see the capsule of the hip joint, which covers the anterior surface of the neck completely, whereas it do not cover the entire posterior surface of the neck. Here you can see it ends 1 centimeter medial to the intertrochanteric crest behind, and above the capsule you are seeing here, this is the Y-shaped iliofemoral ligament. So the upper band and lower band, they have attachment to the intertrochanteric line. Anteriorly what you are seeing there, and medially you are seeing this pubofemoral ligament here, which gets attachment from the lateral part of the anterior border of the superior ramus of pubis, and here you can see iliopectineal bursa. So they will strengthen the capsule of the hip joint, and posteriorly you can see ischiofemoral ligament. So 3 ligaments come from 3 different parts of hip bone. Iliofemoral ligament that you are seeing here anteriorly, iliofemoral ligament from anterior side, pubofemoral ligament from the medial side, and posteriorly you are seeing the ischiofemoral ligament. So these will strengthen the capsule of the hip joint. and to the Fovea Capitis, what is attached? That is ligamentum teres of femur, and you can see here, you can also see some bursas here. That is trochanteric bursa, and this is also trochanteric bursa of the gluteus maximus related to greater trochanter. Now coming to the muscular attachments of the upper end, you can see here, this is the iliopsoas tendon which inserts into the lesser trochanter of the femur, and posteriorly there is bursa which separates it. So iliopsoas is attached to lesser trochanter, and if you take out this rectus femoris here you can see the vastus lateralis taking origin from the upper part of intertrochanteric line. You can see upper part of intertrochanteric line is here, then also anterior surface and lateral part of the greater trochanter you can see here. Then coming to vastus intermedius, it takes origin from the lower half of intertrochanteric line here, intertrochanteric line, and also spiral line, it will take origin from the spiral line, whereas the lateral surface of this greater trochanter gives insertion to gluteus minimus along an oblique ridge, and the lateral surface there is insertion of gluteus medius, and you can see here. As coming to posterior side to the quadrate tubercle, there is insertion of quadratus femoris along the intertrochanteric crest, and piriform fossa to the apex of the greater trochanter. You can see here piriform fossa inserting into apex of the greater trochanter. Then obturator internus with the two gemellae, superior and inferior gemellae. You can see they are attached to the medial surface of the greater trochanter. You can see medial surface of the greater trochanter here. With the two gemellae, superior and inferior gemellae, and if you take out these, that is superior gemellae, obturator internus is here, and if you turn here, here you are seeing that is obturator externus, what you are seeing, that will attach to the trochanteric fossa. You can see, I told you posterior surface of the neck is grooved by tendon of obturator externus. It goes to, being the external, it stays in this guest house formed by trochanteric fossa. Remember trochanteric fossa like a guest house. Whenever an external comes, he resides in the guest house. So obturator externus goes to trochanteric fossa. So these are the attachments of the upper end. Now coming to the shaft of the femur, which is convex forwards because of the pull of the thigh muscles, and you can see it is directed downwards and medially. Shaft is more or less cylindrical, and in the middle 1/3 it presents three borders that you can see here. So this is the medial border that you see, this is the lateral border, and posteriorly you can see this is the posterior border and presents three surfaces, but the posterior border is expanded above and below it is diverging above and below, that we will discuss. In the middle 1/3 you can see these surfaces. This is the anterior surface, this is the medial surface, and if you go here, this is the lateral surface. So it presents three surface and three borders, whereas medial and lateral borders are rounded. The posterior border is thickened and it is called as linea aspera. Aspera means thickened, whereas linea means line. So posterior border is nothing but a linea aspera, thickened line. And you can see here linea aspera has distinct medial and lateral lips, that you can see. Here is the medial lip. This entire thing is medial lip, and this is the lateral lip. And in the upper 1/3 of the shaft, the two lips of linea aspera enclose one more surface, one more additional surface here. You can see they will diverge and enclose one more surface here. So here this part of shaft presents four surfaces: anterior, medial and lateral and posterior. And here you can see a roughened gluteal tuberosity here. This is a roughened area that is called as gluteal tuberosity. And in lower 1/3 also the linea aspera diverge here. In the lower 1/3 also linea aspera diverge to enclose a triangular surface that is called as popliteal surface. This surface forms the part of the floor of popliteal fossa. So again the shaft here has four surfaces rather than three. Only in the middle 1/3 it has three surfaces, that is anterior, medial and lateral surface, whereas here it has four surfaces: anterior, medial, lateral and also posterior surface. Coming to the attachments of the shaft here, you can see mainly to linea aspera, you can see here. So that is the fascia lata that you can see. So what are the attachments to the shaft, that is linea aspera? First you can see here, that is vastus lateralis. From lateral to medial if you go, the first attachment of linea aspera is vastus lateralis. Then you can see the lateral intermuscular septa. We are hiding here, we will hide one by one. First is vastus lateralis, then lateral intermuscular septa. Then here you are seeing the long head of biceps femoris is attached here. Then you can see the short head of biceps femoris. Long head of biceps femoris come from the ischial tuberosity. The short head of biceps femoris come from linea aspera. Then you can see here, that is the posterior intermuscular septa. Then we can see adductor magnus attached to the entire length of medial lip of linea aspera with its osteoponeurotic openings that we discussed in while discussing femoral artery. Four osteoponeurotic openings are there. We will hide these semi-tendinosus and semi-membranosus. They don't have any attachments to linea aspera, but here you can see this is the adductor magnus, and here you can see adductor hiatus, through which femoral artery will continue as popliteal artery. You can hide this. Then here you can see the adductor brevis is attached to the area between the lesser trochanter and the medial lip of linea aspera. And then you are seeing adductor longus attached to the middle 1/3 of the medial lip of linea aspera, similar to coracobrachialis in the upper limb, which inserts into middle 1/3 of the medial border of the humerus. Here adductor longus attached to the middle 1/3 of the medial lip of linea aspera. And if you hide it, then here you are seeing medial intermuscular septa. Then this is the vastus medialis. So these are the attachments of the what you can say linea aspera from lateral to medial. You can remember love is bean, sorry, you can remember it as love is bean and Mr. Bean loves me. That you can see. This is vastus lateralis, then lateral intermuscular septa, short head of biceps femoris, and here you will have posterior intermuscular septa, then adductor magnus, adductor brevis, adductor longus, then here you have intermuscular septa, medial intermuscular septa, then you have vastus medialis. So these are the structures which come from lateral to medial, that is here from lateral to medial, attached to the linea aspera. And if you go above, you can see here this is pectineus muscle attached to the area between the pectineal line. This is the area between the lesser trochanter and medial lip of linea aspera. Then you can see the gluteus maximus here, that is covered by gluteal fascia. You can see it is attached to the here the gluteal tuberosity of the femur, the gluteal tuberosity, that is the attachment. And as you go lower, you can see the medial and lateral lips of linea aspera are diverging there, and they will continue as medial and lateral supracondylar ridges. They enclose this triangular popliteal surface which forms the base of the popliteal fossa, and is covered by popliteal fascia here, which we will take out. And here you can see the plantaris muscle coming from the lower end of lateral supracondylar line, and also you can see the upper part of the lateral head of gastrocnemius come from the lateral supracondylar line of the femur, and medially you can see here the popliteal surface just above the medial supracondylar line of the femur. You can see origin of medial head of gastrocnemius, and you can see the lower end of femur is widely expanded to form two large condyles. One is medial condyle and another is lateral condyle, which are anteriorly two condyles are united and are in line with the anterior surface of the shaft, whereas posteriorly they are projecting here. You can see they are as if projecting from the lower end, and posteriorly they are supported by a notch that is called as intercondylar area or fossa or notch, and project backwards much beyond the plane of popliteal surface of the femur. You can see here is a popliteal surface. They are projecting here like this. The two condyles are partially covered by the articular surface, that is divisible into patellar surface, articular surface of medial condyle, and articular surface of lateral condyle. You can see this is the patellar articular surface, which is extending more over the lateral condyle than the medial condyle, and patella will articulate with the femur here, forming a saddle joint. It is concave from side to side, whereas convex above downwards, extending more onto the lateral condyle than the medial condyle of the femur. And here you can see the articular surface of the medial condyle. You can see. So this is the tibial part. You can see articular surface is directed here. If you see, it It is like this: anteriorly, inferiorly and posteriorly. They form a continuous surface and articulated with the medial condyle of tibia. And here you can see the lateral femoral condyle, articular surface of the lateral femoral condyle. It is also again directed anteriorly, inferiorly and posteriorly like a continuous surface and articulated with the lateral condyle of the tibia. You can see here lateral condyle. The lateral surface of the lateral condyle is flat and vertical and more in line with the shaft of the femur. So lateral condyle bears the brunt of the weight, most of the weight. It is short and stout, whereas a medial condyle of the femur is not much heavier. It is projected more medially, and both the condyles present a prominence. This is the medial, what you can say, supracondylar ridge, medial epicondyle of the femur, and this is the adductor tubercle to which adductor magnus is attached, and the lateral condyle also presents a prominence that is called as lateral epicondyle, and you can see a groove for popliteus here or the lateral surface of lateral condyle. Now coming to the intercondylar fossa or notch, you can see it is limited anteriorly by the patellar articular surface here, whereas posteriorly by the intercondylar line which separates the notch from popliteal surface. You can see this is the intercondylar line which separates it from the patellar surface. Coming to the attachments of the lower end of the femur, you can see here the lateral head of the gastrocnemius takes origin from the lateral supracondylar ridge and also from lateral condyle, and there is also attachment of this popliteus muscle. If you take out here, you can see here that is plantaris. Here you can see the popliteus muscle takes origin from the groove below the lateral epicondyle. This is the groove here. It takes origin from there, and you also can see the popliteus muscle is a unlocking muscle, whereas quadriceps femoris is a locking muscle of the knee joint. And here you can see the fibular collateral ligament, that is, you can see fibular collateral ligament attached to the lateral condyle. It is nothing but a degenerated tendon of the peroneus longus muscle. And one more thing, you can see this is the oblique popliteal ligament attached to the posterior part of the lateral condyle of the lower end of femur. Then coming to the attachments of the medial condyle, you can see the medial head of the gastrocnemius come from the popliteal surface and also upper part of the medial supracondylar ridge of the femur. You can see if you isolate here, this is the medial head of the gastrocnemius muscle. And after hiding the medial head of gastrocnemius, here you can see the tibial collateral ligament, which is nothing but a extension of degenerated tendon of adductor magnus muscle. To the adductor tubercle, you can see the attachment of adductor magnus muscle. To remove all the ligaments, you can see the capsule of the knee joint here, which is attached to the, you can see here along the outer line of the articular surface of the patellar surface and tibial surface. You can see here, this is the capsule of the knee joint, and when you remove the capsule, you can see here spinal membrane. Here you can see the two cruciate ligaments, that is the anterior cruciate ligament attached to the posterior surface here, posterior surface of the posterior part of the medial surface of the lateral condyle, that is the anterior cruciate ligaments. And if you see here, there is one more ligament in that intercondylar notch. This is the oblique popliteal ligament derived from the semimembranosus muscle, and here you can say this is the posterior cruciate or posterior meniscofemoral ligament. I'll hide this, and here you can see this is the posterior cruciate ligament attached to the anterior part of the medial surface of the lateral surface of the medial condyle. This is the posterior cruciate ligament. So anterior cruciate ligament is attached to posterior part of medial surface of the lateral condyle, whereas the posterior cruciate ligament is attached to anterior part of the lateral surface of medial condyle. So intercondylar area gives attachment to these two cruciate ligaments, which form the main bonding between femur and tibia. Coming to the ossification, so the shaft of femur ossifies by one primary center which appears during the 7th month of intrauterine life, whereas the upper end ossifies by three secondary centers, one for the greater trochanter, one for the head, and one for lesser trochanter. For the head, it appears around 6 months and fused by 18 years. For greater trochanter, it appears around 4 years and fused by 18 years. For lesser trochanter, it is 12 years and fused by 18 years, whereas the lower end, it is around 9th month and fused by 20 years. So this is the ossification of the femur. You can see here the nailing is used, that is the intramedullary internailing of the femur. So this trochanter shaft angle helps in that, which marks the junction between the spongy bone and cortical bone. Coming to the blood supply of the femoral head, you can see here, you can see there near the Fovea Capitis, the ligament arteries. So the head of the femur is mainly supplied by the medial and lateral circumflex femoral branches of the profound femoral artery and obturator artery, and also branches from superior and inferior gluteal arteries. You can see, and you can see there obturator artery supplying there. And coming to the femoral, this is a femoral artery. It gives profunda femoris branch. It will give the lateral circumflex femoral artery and medial circumflex femoral artery. The branches from the lateral circumflex femoral artery supplies the anterior part of the ring, whereas the branches from the medial circumflex femoral artery supplies the posterior part of the ring around the neck of the femur. So then these branches will pierce the joint capsule, that you can see attached anterior to intertrochanteric line, posteriorly medial to intertrochanteric crest. These branches will pierce and supply the remaining part of the neck, and these branches are called as retinacular arteries. These are the retinacular arteries which form a series of these arteries. These are anterior, posterior superior and posterior inferior. The main contribution is formed by the medial circumflex femoral artery. and they go near the head of the femur, whereas in the childhood the ligamentum teres carries the branch from the obturator artery which supply the head, because there is no fusion between the head and the remaining part of the upper end. You can see these vessels form subsynovial arterial ring and supply the cartilage, the head of the femur. Again you can see the branches, epiphyseal branches are coming there and supplying the head. Obturator artery supplies, that is called as foveal artery, passing through ligamentum teres only in the childhood, but in the adult age it is mainly supplied by these circumflex femoral arteries only. So you can see age changes. Less than 4 years it is supplied by the obturator artery. After that it is covered by these retinacular vessels coming from lateral and medial circumflex femoral arteries, and these arteries are damaged during the fracture of neck of femur, leading to avascular necrosis. The fracture of neck is classified on the Gardner's classification. It depends depending on the amount of displacement or risk of vascular occlusion. This classification applies to geriatric and insufficiency fracture due to osteoporosis. You can see the 4 types there: non-displaced and displaced. And one more type of classification is Powell's classification. It is according to orientation and direction of the fracture line across the femoral neck. So femoral neck fracture usually associated with the femoral shaft fractures that you can see here. Treatment is by the intramedullary internailing. You can see those are the nailings and platings you can see there.